Namaskar. My presentation is on SS cavity pathway to the success of endodontic treatment. I am Dr. Promila Verma, and this is my university, King George's Medical University, Lucknow, India. First of all, I would like to thank Omics Group for inviting me to the 5th American Dental Congress for present my paper. Access is success. These three words by Frank P. in a nutshell convey the message that a proper design of an SS cavity will ultimately lead to the success of an endodontic treatment. So what is an SS cavity? SS cavity, according to Cohen, is a cavity preparation generally refers to the part of the cavity from occlusal table to the canal orifice. The triad of endodontic treatment includes SS cavity, biomechanical preparation, irrigation, and three-dimensional obturation of the canal. All these three steps, they are very important for the success of an endodontic treatment. But SS cavity is the initial step, the first initial mechanical step, which influences the other subsequent steps for the success of endodontic treatment. Preparation of endodontic treatment can be one of the most challenging and frustrating aspect of endodontics, but it is the key factor for the success So we may say that good SS cavity design may result in identification and subsequent disinfection and obturation of the entire root canal system. An inadequate SS may result in difficulty in negotiating and locating the canal, biomechanical preparation, and the three-dimensional obturation of the root canal. So what are the pre-analysis for the SS cavity? For the success of an endodontic treatment, the clinician must be aware of the root canal morphology, which is a very complex. There are several researchers have tried to classify the complex root canal anatomy for easy understanding, and one of the most accepted classification is Vertucci classification, who has classified the root canal morphology into 8 types, with the type 1, where the single canal from the pulse chamber to the apex of the canal. Type 2, 2 canals leave the pulse chamber, but they unite short of the apex and leave the apex as a single canal. Type 3, where the single canal, they divide in the body of the root into 2 canals, but they leave the chamber as a single canal. Type 4, 2 canals from pulse chamber to the apex. Type 5 is somewhat complex. They divide in the body of the root and leave as 2 root canals from the 2 different apex. Type 6 is when the 2 canals leaves the pulse chamber, but they unite in the body of the root and again redivide. Type 7 is a complex type of anatomy where the single canal, they bifurcate, they again unite and then again redivide. And type 8 is 3 canal from pulse chamber to the apex as a different canal. So before starting, so we must analyze the pre-SS analysis, that we must have a good periapical radiograph. A good periapical radiograph is an immense help to the clinician, because it helps the clinician to identify the external and internal anatomy of the tooth, the number of canal present, the dilacerations, its curvature. But the knowledge provided by the radiograph is limited, because it's a 2-dimensional image of a 3-dimensional object. So if the clinician can go for some advanced diagnostic aid like CBCT, it can be of immense help for locating the canals. There are various researchers who have taken the use of CBCT and have concluded that CBCT images always resulted in identification of greater number of root canals system than digital images. There are other researchers who have concluded that, the third is the illumination and magnification. As has been earlier said in the previous lectures, that the dental operating microscope, they provide a wider view of the working area and help in identifying some missing or hidden canals, calcified canals. So there are some researchers who have concluded that operating microscope and CBCT scanning were important for locating and identifying the root canals, and CBCT scanning can be used as a good method for initial identification of maxillary first molar internal morphology. The other instrument for the pre-SS is the isolation. Isolation is an immense help to the clinician because it helps to isolate, retract the soft tissue from the working area and help to prevent the slippage of some seepage of saliva into the SS cavity, and also prevent the accidental slippage of some small instrument into the pharynx. The proper armamentarium required is a small size ultrasonic handpiece which help to treat the patient in the more inaccessible area. The burrs required the round burrs of different sizes, the endo-SS burr, endo-Z burr for locating the canals, endodontic explorer, endodontic spoon excavators, and operative explorer. Ultrasonic units and tips are immense help to the clinician because it helps in refining the SS cavity. These ultrasonic, the endodontic explorer, they help in the locating some hidden canals, help in the flaring and exploration of the canals. The ultrasonic tips, they are of helps in the refining the SS cavity over the use of burrs. Because it provides an unobstructed view. These ultrasonic tips, they provide an unobstructed view under magnification, thus allowing the clinician to make a direct contact with the working area, and he can manage it well. The size of these ultrasonic tips, they are smaller than the size of the smallest size of the burr. So these smaller size ultrasonic tips can be useful in brushing of the dentine more easily till the pulp chamber is seen. This ultrasonic dip promotes bubbles in water which bathes in the tip, and these bubbles, they generate some shock waves in the working area, thus facilitating the removal of the remnant and debris present in the, thus creating a clean SS cavity. So what are the objective of SS cavity preparation? The objective is to conserve sound tooth structure as much as possible while locating all the root canal orifice. It should permit the complete removal of pulp chamber and have a direct line SS till the apical foramina. Our SS cavity should be such that there should be an easy insertion of the endodontic instrument into the canal and allowed complete irrigation, shaping, cleaning, and quality obturation. So for the ease of studying, the stages of SS opening can be divided into 7 stages, and it will be taken one by one. The first stage is relieving the occlusion. The relieving the occlusion, this is the first step in preparing the SS cavity because it reduces the post-operative discomfort to the patient by relieving it from the trauma from occlusion, and it helps the clinician to establish a occlusal reference point for determining the working length of the canal, and it also improves the convenience for the operator. The stage 2, we can use the caries as a guide. All the caries portion should be removed before initiating the going into the canal, because these caries may serve as a infective. So and also these caries, they anywhere the caries, the site is present, they will ultimately lead to the pulp chamber. So we have to remove all the caries. The next stage is that we have to follow some laws of SS opening, which has been given by Krensner and Rancourt. So the hiccup for the clinician while doing an SS opening, that he may land into accidental perforation. And this can be avoided by knowing that he must be aware of the geography of the tooth, because of external and internal morphology of the tooth. So one of the major key factor for locating the pulp chamber is the cemento-enamel junction. The cemento-enamel junction is the most important landmark for locating the pulp chamber. And this can be, the clinician can start this mentally visualizing the cemento-enamel junction by moving his probe into at the level of the cemento-enamel junction, and he can mentally visualize the shape of the SS cavity. The laws given by Krensner and Rancourt, this law of centrality. The law of centrality states that the orifice of the pulp chamber floor is always located in the center of the tooth at the level of the cemento-enamel junction. And law of concentricity is that the wall of the pulp chamber is concentric to the external morphology of the tooth at the level of cemento-enamel junction. And the law of cemento-enamel junction states that the wall of the pulp chamber is equidistant from the external surface of the tooth at the level of the cement. So this is the mental picture which the clinician must be aware while doing an SS cavity. The next stage is de-roofing of the pulp chamber. De-roofing of the pulp chamber is the most important step while preparing a root canal. So an untreated tooth from occlusal or incisor surface is the maximum height is 7 mm. So the clinician can measure this height he can adjust this depth in the burr and can place it, measure this depth, and then he can penetrate the pulp chamber from the central portion of the occlusal surface of the tooth, and when this depth is reached, the 7 mm depth is reached, then he can do little cutting to do to locate the canals. So once the SS cavity is prepared, we can there are certain clues to the location of the orifice. If a single canal is present, the orifice will be located in the center of the tooth. And if the SS cavity, shape of the SS cavity is oval, then always go search for some another canal. And if the orifice is present off-centered, then there are chances that other canals is present, so we must try to locate the canals. If the two canals, they are very close together, then it is confirmed that the canals will join at some point in the body of the root. And if the canal orifice, they are apart, the canals will remain separate, and then there are less chances of curvature. Next stage is to observe the color change. The color change is a guide for the endodontics, and as we know that the color of the enamel is white, dentine yellow, floor of the pulp chamber is grey. Root canal orifice, they are dark grey or black in color. So the law of color change states that the color of the pulp chamber floor is always darker than the walls. So once there is a color change, we can know that the pulp chamber floor is reached, so we can stop negotiating further. Establish a straight line SS. Straight line preparation provides an straight or outwardly flared unimpeded path from the occlusal surface to the apex. To test for the straight line SS, a file is inserted into the canal, and it is seen that if it goes undeflected till the apex, then a straight line is achieved like this. If there is some obstruction, so it will hamper the further steps of endodontic preparation. And undeflected files, they they work under more stress, and then there are chances of instrument breakage, and it may also lead to some jipping, perforation, etc. into the canal. And an undeflected file will serve as a guiding force because it helps in the tactile feel of the canal anatomy and the movement of the files in the canal. The last stage is the locate the canals, which can be an aha moment or an eureka moment for the clinician because he is in a stage of locating the canals. So there are certain laws which has been given by Krasner and Ranko, which must be followed by locating the canals. The law of symmetry. The law of symmetry once stated that except for maxillary molars, the canals are equidistant from the line drawn in a mesiodistal direction, which is in the center of the tooth. The law of symmetry too states that the orifice of the canals are located perpendicular to the line drawn to the line from mesial to distal direction from the center of the tooth. The law of orifice location 1 states that the orifice of the canal is always present at the junction of the wall and floor of the pulse chamber. The law of orifice location 2 states that the orifice is always located at the vertices of the wall and floor junction, and the law of orifice location 3 states that it is present at the root developmental fusion line. So, there are some guidelines for locating the SS cavity. In maxillary anteriors, we can divide the lingual surface of the maxillary anterior into 9 compartments, and the center one is the site for penetration for locating the canal. So the burr is placed perpendicular at this point and is penetrated, and then it goes parallel to the tooth for reaching into the canal, and the shape of this is oval in shape. For mandibular molars, a smaller size of the burr is used, like number 2 diamond burrs, and while changing the position of the operator at 12 o'clock position, he can gain an direct SS, and there is also can take some radiographic position by changing the angulation, so that there are chances that more canals are present in the mandibular anterior. Maxillary premolars, the key rules that the orifice is buccolingual orientation and oval shaped SS is present, and if we can see that the bulky root are present in the radiograph, then there are always chances that we must suspect an extra canal. For the mandibular premolars, the shape is ovoid or round shaped, and in case of bulbous root, we can suspect for bifurcation of the canals in the root. The key rules for tracing the canals in the maxillary rule is that all the canals are present in the maximum mesial root in 60% of the tooth, and the palatal canal is present under the palatal cusp. The straight line from palatal canal orifice towards the buccal side gives a distobuccal canal. We can find the distobuccal canal. And mesial line from distobuccal canal will give you the location of the mesiobuccal canal. In molars, maxillary molars is trapezoidal in shape, and as always we should try to suspect for the 4th canal. The possibility of second distal canal, which can be in the following configuration, is C-shaped canals and 2 canals with orifice very close together, and 2 distinct orifices they are present. So the clinician always try to do a proper SS cavity design will always lead to all the canals, but there are some errors which can be found while preparing the SS cavity. They are that if an inadequate extension of the SS cavity may lead to some hidden canal which are left undiscovered. So the SS cavity must be extended to locate all the canals. If there is an inadequate access in the molars, they may also lead, maybe undiscovered distobuccal canal may be left untreated. So it means that proper extension should be given for locating the canals. Overextension will lead to compromise the strength of the tooth that will not be able to serve for the future treatment because it may get fractured. There are chances that we may allow the debris to accumulate into the canal, which may lead to coagulation, blockage of the canal. So a continuous irrigation must be done to prevent the blockage of the canal while doing the SS opening. There are chances that a complete de-roofing of the pulse chamber is not achieved, and this can be by taking the bite wing radiograph is an excellent aid in determining the vertical height of the pulse, so that we can remove the roof of the pulse chamber and the content of the pulse chamber is completely removed. There are chances that for improper angulation while doing an SS opening, there may be a perforation. So a proper knowledge and anatomy of the tooth will help the clinician to avoid this step. There are chances that the furcation involvement, the clinician may land into the perforation at the furcation, and so that will also lead to the weakening of the tooth and periodontal problems. So concluding that restoration of the normal function and structure of the tooth is ultimate goal of endodontic treatment. It is only after correct SS cavity preparation that the clinician can perform thorough shaping and cleaning and three-dimensional obturation of the root canal, which is essential for the desirable outcome. Thank you.